Imagine for a moment, you're trying to fix a leaky pipe in your house. But instead of, grabbing a wrench or wrapping it in some Teflon tape or getting a new brass valve, you take a syringe.
Right.
You draw some of your own blood, you spin it in a machine, and then you just inject that blood directly into the pipe and tell the pipe to heal itself.
Wow. Yeah, I mean, it sounds completely counterintuitive.
It sounds a bit like science fiction, right?
It really does. I mean, it defies everything we intuitively understand about plumbing or mechanical failure and structural repair.
Yeah.
But, well, human biology is just far more dynamic than a copper pipe.
It definitely is. And welcome to this deep dive, by the way. Today we are pointing that exact concept, so injecting blood to fix a structural leak, at a really highly specific, very personal question for you, the listener.
Yeah, exactly.
We want to just cut through the noise, the glossy marketing and the dense medical jargon to find out how effective is the O-shot for bladder leakage.
Right, and to figure this out, we've gathered a really fascinating and, honestly, at times, quite contradictory stack of sources.
Very contradictory.
Yeah, so we're examining peer-reviewed systematic reviews from medical publishers like MDPI and Frontiers. We have some raw clinical trial data. We're looking at official medical insurance policies, specifically from Wellmark. And then we're putting all of that rigorous science right up against the really bold marketing materials you'll find straight from aesthetic clinics.
Right. And the mission here isn't just to, deliver a flat yes or no. Health is rarely that simple. I mean, almost never.
Almost never, yeah.
We want to help you understand the pretty massive gap between those commercial promises and the actual clinical reality regarding this specific treatment for what the medical community calls stress urinary incontinence, or SUI.
Yeah, SUI. But before we actually analyze whether tricking the body into rebuilding tissue stops the leaking, we really have to look at the daily lived experience of the problem itself.
Let's do that.
So, stress urinary incontinence, it affects a staggering 423 million women globally.
Wow.
Yeah. This is an incredibly common condition, yet it just remains heavily stigmatized and, rarely discussed openly.
423 million women. I mean, that is a massive demographic of people who are probably constantly mapping out public bathrooms.
Right.
Or carrying extra clothes or just feeling really anxious every single time they feel a sneeze coming on.
Yeah, exactly.
So what is actually breaking down in the body to cause this?
Well, mechanically, SUI happens when physical exertion increases the intra-abdominal pressure inside your body.
Okay, so things like what?
Things like coughing, laughing deeply, sneezing, jumping, or even just lifting a heavy box.
Right.
In a fully healthy, robust pelvic floor, the muscles and the urethral support structures, they easily absorb that sudden spike in pressure. They keep the urethral valve clamped shut.
Makes sense.
But in SUI, those support structures have essentially been compromised.
And what usually causes that compromise? Because we hear a lot about, childbirth and menopause being the primary culprits.
Yeah, those are really the two major catalysts. So during childbirth, the sheer physical trauma can stretch and damage the pelvic nerves.
Ouch. Yeah.
Yeah, weakening the muscles they actually control. And then later in life, during menopause, the sudden drop in estrogen causes the tissues in the pelvic region to just lose their elasticity and strength.
Oh, because the collagen degrades.
Exactly, the collagen degrades. So when that sudden pressure hits from a cough or a laugh, the weakened structural support simply gives way. The valve gets forced open, and that results in an involuntary leak.
Right. And if you start searching for solutions to this online, beyond just doing daily Kegel exercises, you are inevitably going to see ads for something called the O-shot.
Oh, definitely.
And the very first thing we need to clarify from our stack of sources is that the O-shot is not a scientific term.
No, not at all.
It is a commercial trademark.
Yeah, it's a heavily marketed, branded term. When we actually look at the clinical trials, the procedure is referred to as periurethral or vaginal platelet-rich plasma therapy.
Okay.
Or PRP for short.
PRP. Which brings us to the actual procedure, because the mechanism here is honestly fascinating. Let's unpack this and walk through what a patient actually experiences.
Sure.
So a doctor draws a small vial of your blood, similar to just a routine physical. Then they take that vial and place it into a high-frequency centrifuge.
Right, and the centrifuge is the critical step here.
How so?
Well, it spins the vial at incredibly high speeds to separate the components of your blood based entirely on their density.
Oh, okay.
Yeah, so the heavier red and white blood cells are forced to the bottom, and that leaves this golden, sort of straw-colored liquid at the top. And that liquid is the platelet-rich plasma.
Now, most of us just think of platelets as the things that, make our blood clot when we get a paper cut.
Right.
Why are we trying to isolate them for this?
Because platelets are essentially the body's microscopic first responders. Beyond just clotting, they are packed with highly active glycoproteins.
Okay, lost me a bit there with glycoproteins.
Sorry, specifically chemokines and cytokines.
Still sounds intense.
I know. But the real magic lies in the essential growth factors they carry, particularly two called VEGF and PDGF.
Okay, let's translate those acronyms because they do sound incredibly dense. What are VEGF and PDGF actually doing in the body?
So VEGF stands for vascular endothelial growth factor. Its primary job is to stimulate angiogenesis,
Which is?
the physical creation of brand new blood vessels.
Oh, wow.
Yeah, it essentially paves new vascular highways to bring oxygen and nutrients to damaged areas.
That's wild. And the other one?
Then you have PDGF, which is platelet-derived growth factor. This acts like a biological siren. It signals local cells to rapidly divide, multiply, and start synthesizing new tissue.
Okay, so it's essentially like taking your body's own biological spackle and fertilizer.
I love that.
You concentrate it into a superdose and then inject it into weakened tissue to force it to rebuild.
That is a brilliant way to visualize it. Biological spackle and fertilizer.
Thank you.
Yeah. So when a doctor injects this concentrated serum directly into the anterior vaginal wall and the tissue surrounding the urethra, the whole goal is to wake up what are known as unipotent local stem cells.
Unipotent meaning they have one very specific job, right? In this case, repairing the local pelvic tissue they already reside in.
You've got it. The sudden influx of these concentrated growth factors tricks the body into launching this massive, localized healing cascade.
Right.
The VEGF builds new blood vessels, increasing blood flow.
Yeah.
The PDGF prompts the creation of new collagen to thicken and tighten the connective tissues.
Wow.
It even encourages nerve repair. The entire biological theory relies on the idea that regenerating these tissues restores the structural integrity of the urethral sphincter, giving it the physical bulk and strength needed to stay closed under sudden pressure.
I mean, the theory sounds incredibly elegant.
It really does.
Yeah. It makes complete logical sense. But human biology on a cellular level is notoriously messy when you actually put it inside a living, breathing person.
Exactly.
So did tricking the body into rebuilding this tissue actually stop the leaking in real patients?
Right. So to answer that, we have to look closely at the pilot studies. One trial that really stands out in our research comes from Government Doon Medical College.
Okay.
They conducted a prospective pilot study on women diagnosed with stress urinary incontinence. And the crucial finding there involved the patient profile.
What did they find?
They found that women with mild SUI saw the best improvements in leakage episodes after receiving 2 injections of PRP, spaced about 6 weeks apart.
Okay, so the severity of the leak going into the treatment matters immensely.
Oh, absolutely. It dictates the outcome. We see this play out in another significant piece of data from a study by researchers Chang and Kuo.
What did they look at?
They looked at a very specific, much more severe subset of patients, women with intrinsic sphincter deficiency, or ISD.
Okay, how does ISD differ from standard stress incontinence?
Well, ISD is a severe failure of the valve itself. The sphincter just fails to close properly at all, which often results in severe leaks, even without much physical exertion.
Oh, I see.
It's a much harder mechanical problem to fix.
Right. So what happened when they treated these women with severe ISD using the platelet-rich plasma?
So the Chiang and Ku study reported an overall success rate of 50%.
Okay.
Specifically, 46.2% of the patients achieved complete dryness immediately after the therapy.
Immediately. Wow.
Yeah. And when they followed up at 12 months, 26.9% of those women had maintained that complete dryness.
That is a fascinating paradox. I mean, we are talking about a severe condition, and yet almost half the women saw immediate, complete relief.
Exactly. And what's fascinating here is the researchers didn't just rely on subjective questionnaires, asking the women how they felt.
Right. Self-reporting can be tricky.
Yeah, so they measured objective urodynamic parameters. They tracked the abdominal leak point pressure.
Explain how they measured that pressure mechanically, just for a visual.
Sure. It's exactly what it sounds like. It's a test to find the exact amount of abdominal pressure the bladder can withstand before the valve fails and urine leaks out.
Okay.
Think of it like inflating a balloon and measuring exactly how much force it takes to squeeze water out of the nozzle.
Got it.
In this study, the pressure resistance actually increased from an average of 117.5 to 133.6 centimeters of water.
Wow, so that is a measurable physical increase in the urethra's ability to stay clamped shut.
Yes, exactly.
Okay, I have to pause, though, and look at the broader picture here, because I feel like there's a glaring issue with these numbers.
Let's hear it.
The Dune Medical College study looked at 15 women,
Right.
and the Chang and Ku study involved 26 women.
Yes.
That is incredibly small. I mean, how much weight can the medical community really give to a 50% success rate when we're only talking about 24 people in a trial?
That is the exact tension plaguing this entire field of treatment.
Yeah.
Your skepticism is entirely validated by the broader medical literature.
It just feels so anecdotal.
It is. While 13 women getting completely dry out of 26 is undeniably life-changing for those 13 individuals.
So, for sure.
It's hardly a definitive population trend.
Right. It's a promising anecdote, but it isn't a gold standard medical consensus.
Precisely. While these early observational pilot studies do consistently show a 50 to 70% reduction in pad usage and improvements in validated incontinence scores, the systematic reviews issue a very clear warning.
The larger studies from MDPI and Frontiers.
Exactly. The ones that analyze the methodology of all the smaller pilot studies, they consistently classify the current evidence for PRP in treating SUI as low quality.
We should probably clarify what low quality means in a clinical context, right? Because it doesn't necessarily mean the treatment is a scam or fake.
No, not at all. It means the methodology used to prove it works just isn't robust enough yet. The systematic reviews point out the incredibly small sample sizes, like you noticed.
Yeah.
They highlight the lack of long-term follow-up data. They also note massive variations in how the PRP is actually prepared.
Wait, how can it vary? Isn't it just a centrifuge?
Well, different brands of centrifuges yield different concentrations of platelets, which makes it really hard to standardize the dose across studies.
Oh, that makes sense.
And most importantly, the field currently lacks large, randomized, double-blind, placebo-controlled trials. The foundational science is simply in its infancy.
And because that rigorous science is still in its infancy, this massive gap has opened up. On one side, you have cautious, peer-reviewed medical data warning of small sample sizes.
Right.
And on the other side, you have commercial aesthetic clinics aggressively marketing this procedure.
And the contrast is jarring. If you look at the clinic sources we gathered, the places actually selling the O-shot to consumers, the claims are incredibly bold.
Yeah, many of them explicitly state the procedure is 90% effective.
Yeah, 90%.
They also bundle the claims. The marketing suggests it can cure incontinence while simultaneously heightening libido, increasing natural lubrication, and delivering stronger, more frequent orgasms.
Right. It's marketed to the consumer as this comprehensive magic potion for pelvic rejuvenation.
Basically.
But when we pivot away from the clinic brochures and look back at the clinical reality, we have to look at the Dinesh Paju randomized clinical trial.
Okay, what did that one show?
This was a crucial study because it directly compared PRP injections to the current surgical standard for stress urinary incontinence, which is the midurethral sling.
Okay, let's explain the sling really quick, because that gives us a baseline for what a gold standard actually looks like in this space.
Sure. A midurethral sling is essentially a permanent synthetic hammock. A surgeon places a piece of surgical mesh under the urethra to physically support it. Yeah, it's a real surgery. And when intra-abdominal pressure increases, the urethra is pressed against this synthetic hammock, which forces it to stay closed.
So it's a permanent mechanical fix.
Yes. And the Dinesh Paju trial confirmed that traditional surgery remains objectively superior to PRP for resolving SUI.
So surgery wins out.
It does. The symptom reduction and the objective dryness rates were significantly higher in the surgical group.
Right. We also need to look at how the broader medical establishment and, the financial gatekeepers view this.
Insurance companies.
Exactly. We examined medical policy documents from major insurers, specifically Wellmark, and they have a very clear stance.
Very clear.
They strictly classify the use of PRP for non-orthopedic conditions, which explicitly includes urinary incontinence, as investigational.
And investigational is a critical medical legal label.
What does it mean practically for the patient?
It means the insurer has reviewed the available literature and concluded there is currently insufficient evidence that PRP improves net health outcomes compared to standard treatments.
So they won't pay for it.
Exactly. Therefore, using PRP for bladder leakage is an off-label use. It will almost certainly not be covered by insurance.
Mm.
For the patient, it's an out-of-pocket, outpatient aesthetic procedure.
Thousands of dollars, usually. And if you dig deep enough into the fine print of even the most reputable clinics, they eventually admit a crucial caveat.
What's that?
PRP really only shows promise for mild to moderate stress incontinence.
Right.
If you have severe SUI or if you have urge incontinence, which is entirely different, by the way.
Oh, yeah, totally different mechanism.
Yeah, urge incontinence is characterized by a sudden, uncontrollable need to urinate, often caused by nerve or bladder muscle spasms, not physical pressure. So if you have that, PRP is not the established treatment.
This really highlights the danger of trademarking medical procedures. Creating a brand identity like the O-shot allows the commercial narrative to just vastly outpace the peer-reviewed data. It places a massive burden on individual practitioners to manage patient expectations and explicitly inform them that surgical interventions remain the objective gold standard for a cure.
Okay, so what does this all mean? This brings up a really important question.
Let's hear it.
If the randomized trials prove that surgery is objectively superior and your health insurance outright refuses to pay for PRP because it's investigational, why are patients and doctors still so incredibly interested in this blood injection?
That's the real question.
I mean, why would anyone choose a $1,000 out-of-pocket O-shot over a highly effective insurance-covered surgery? Is this just a stepping stone for people who are terrified of going under the knife?
It largely comes down to the risk profile. Yes, the midurethral sling is highly effective at stopping leaks, but the potential complications are severe and life-altering.
Surgery is never just a simple risk-free fix. We all know that.
Far from it. With synthetic mesh slings, patients face risks of massive hemorrhage during the procedure. They face voiding dysfunction, where the sling is pulled too tight and they suddenly cannot empty their bladder at all.
That sounds awful.
There are risks of chronic, debilitating pelvic pain. And most concerning is mesh erosion.
What is that?
That's where the synthetic plastic mesh actually wears through the vaginal wall over time, requiring complex reconstructive surgeries to remove it.
Oh, wow. Okay. But what about the non-surgical options that existed before PRP? Weren't there other injections people could get?
There were, and they carry their own severe risks. Before PRP, doctors relied heavily on synthetic bulking agents, like a product called coaptite.
Okay.
They would inject this synthetic paste around the urethra to bulk up the tissue and force the tube closed.
But the human body doesn't always like synthetic pastes.
Exactly. The human body often attacks synthetic agents. Those pastes have been known to cause painful hard nodules called granulomas or trigger severe inflammatory responses that completely block the urethra.
Oof. If you are listening to this right now and imagining any of these complications happening in such a sensitive area of your body, the appeal of an alternative becomes incredibly clear.
Very clear.
This is where the concept of an autologous treatment changes the conversation entirely. Right?
Exactly. Autologous simply means the treatment is derived entirely from your own body. Because PRP is just your own spun-down blood, the risk of an allergic reaction is effectively zero.
The body knows its own blood.
Right. The risk of tissue rejection is zero. The body is not going to form a granuloma fighting off a foreign synthetic paste because it perfectly recognizes its own platelets. In every study we reviewed, the adverse events for PRP were remarkably minimal.
Mostly just mild, transient discomfort or slight bruising at the injection site, right?
Exactly.
But let's be real with the listener for a second. If you were imagining getting a needle injected into the anterior vaginal wall, you were probably cringing.
Yeah.
It is minimally invasive, but is still a needle in a highly sensitive area.
It absolutely is, though clinics generally use a strong local anesthetic to manage the discomfort. But beyond the immediate procedure, the true cost is patience. The protocol is a huge commitment.
Walk us through that timeline. What does it actually look like?
The standard clinical protocol usually involves injecting 5 to 6 milliliters of PRP into the periurethral area once a month for 3 consecutive months.
Okay.
And because we are relying on biological regeneration, waiting for the VEGF to build blood vessels and the PDGF to point collagen growth, patients must be willing to wait up to 3 months after their final injection to see the peak regenerative effects.
So you are not walking out of the clinic perfectly dry that same afternoon?
No, definitely not. Tissue regeneration operates on its own timeline.
But for a woman who has spent years mapping out bathrooms,
Right.
who hasn't found relief with pelvic floor physical therapy, but who is entirely unwilling to accept the terrifying risks of synthetic surgical mesh, PRP represents a very low-risk compromise.
That's exactly it. It is a middle ground between doing nothing and going under the knife.
We have covered a massive amount of ground here, navigating between the biological promise and the clinical limitations. Let's synthesize everything we've learned from our sources.
Okay.
The O-shot, or periurethral PRP, is an undeniably promising, remarkably safe, and biologically fascinating tool for women dealing with mild to moderate stress urinary incontinence.
It is.
Hmm.
It leverages the body's own innate healing mechanisms to rebuild weakened structural support. But it is vital to remember it's not a guaranteed instantaneous fix.
Right.
It requires multiple treatments, patience, significant out-of-pocket expense, and most importantly, it currently lacks the large-scale rigorous data needed to actually dethrone traditional surgery.
It is essentially a calculated biological gamble, a very safe gamble, but a gamble nonetheless.
The underlying mechanism, though, leaves us with an incredibly profound question to ponder.
I'm intrigued. What is it?
Well, if isolating and injecting our own concentrated blood can prompt our bodies to rebuild and thicken weakened urethral tissue, what other failing, aging structures in our bodies could we theoretically trick into repairing themselves?
Wow. It completely flips how we view the physical decline of aging.
Are we looking at a future where the primary medicine we use to heal the physical wear and tear of our bodies is just a recycled, concentrated version of ourselves?
That's a wild thought.
Right. Instead of relying on foreign metals, synthetic plastics, or chemical pills, we just feed our failing structures the exact biological blueprints they need to rebuild.
A biological patch for a mechanical problem. It really makes you wonder what else our bodies are capable of fixing if we just give them the right concentrated instructions.
Exactly.
Thank you for joining us on this deep dive. We hope this exploration empowers you to keep asking the tough questions, to always look past the glossy marketing hype in your own health journeys, and to remember that sometimes the most fascinating medical advancements are hiding right there in our own biology.